You've definitely heard this one before. He won't move his neck. Or, she woke up from her nap and is just looking at me weird. You think, stiff neck. I remember what this is called. It's Latin, right? Torticollis. Done. I figured it out. Yes. Torti, twisted. Collis, neck. Torticollis. A wry neck is just the starting point, naming what you see. But torticollis is just a finding. We have to get to the cause, or at least rule out the dangerous etiologies. What could we be missing? Is it just a muscular spasm? Somehow traumatic? Infectious? A tumor? Maybe even the result of a congenital condition? Diphenhydramine doesn't fix everything after all. What to do with the stiff neck? Next on the Playbook.
You make tough calls when caring for acutely ill and injured children. Join us for strategy and support through clinical cases, research, and reviews, and best practice guidance in our ever-changing acute care landscape. This is your Pediatric Emergency Playbook.
Welcome to the Playbook. I'm your host and coach, Tim Horechko. Marco is a 5-year-old boy with trisomy 21 who's brought in by his mother for not moving his head since he got up from his nap this afternoon. His mother put him to bed, only about a half a foot above the ground, tucked him in, slept. Everything was fine, but he woke up crying. You ask if there was anything unusual about the day. No. Did he fall? She doesn't think so, but she did find him sitting up against his bed with his blanket around him. You look at Marco, and he's quiet in his mother's arms. He's shy, he isn't saying much. You see that he holds his head so that the left ear is close to the left shoulder, and his chin is facing slightly away, pointing to his right shoulder. You do a very nice, thorough head-to-toe exam, and you save the head and neck for last. There's no other trauma. He has normal circulation. His belly is normal. Marco is not happy with your getting close to his neck. You go behind the chair he's sitting in with his mom, and you keep chatting with her to get the rest of the routine history so that you don't make it weird for Marco. The right side of his neck is the most accessible to you. You palpate carefully along the sternocleidomastoid muscle on the right. There's no particular tenderness. Even the muscle belly on the left doesn't appear to be too tense or tender. This isn't torticollis from a muscular strain. You remember that the most common type of cervical subluxation in children is rotatory subluxation. Gently you trace your fingers up his spinous process, starting low around C7 or so. Yes, that one's in line. This one's in line. Yes, you think you feel something maybe out of place at about C1. It's off to the left. You tell mother that you're going to give Marco some good pain medication. You can do a better exam, but in the meantime, I'm putting a size 3 cervical collar on him until we can figure this out. Marco likely had a minor trauma, just rolling out of bed, but that's enough to cause rotatory subluxation of the cervical spine in any child, but some are at higher risk. Remember that children with trisomy 21 or Down syndrome have ligamentous laxity and can have atlantoaxial instability. They can rotate their individual cervical vertebra, and once the pars articularis are out of joint, they get stuck right there. There's some other less common syndromes that are associated with minor mechanism in rotatory subluxation in children, like juvenile idiopathic arthritis or really any connective tissue disorder. You could try plain films first, but really, why? You know you're going to need to get a CT of the cervical spine regardless, since plain films are not perfectly sensitive, and you would need a perfectly open mouth to get that odontoid view on plain films, and Marco is just not here for it. So you scan him. Yes, rotatory subluxation, C1 on C2. There's no fracture. There's no bony congenital issues. There's no really great way to treat this. If the pain is severe or if there are any neurologic findings at all, then yes, you're going to need to speak with a neurosurgeon and consider something aggressive like cervical traction, or even if all of that else fails, surgery. But I'll tell you that it's pretty rare, and if the child has a normal neuro exam, if his pain is controllable, he gets a soft collar, he gets analgesia, and he gets rest. The joints, the muscles, the ligaments, they want to go back into place. With a little bit of relaxation of the muscles, from NSAIDs and from rest, it usually resolves in a few days to about a week. Close follow-up from Marco, soft collar, analgesics, and good return precautions. Sylvia is a 4-year-old girl with no past medical history. She's brought in by her father because she woke up with a stiff neck. She had what seemed to be a viral respiratory illness about a week ago. It improved. Sylvia sits in her father's lap. She's still, with her eyes to the floor, chin down, her head tilted slightly to the left. She does not want to move. You try to get her to look up at you, but she refuses and she clings even more tightly to her father. So you work around it. Her cervical spine is normal. There's no tenderness of palpation. She seems more upset the more you palpate the soft tissues. But truthfully, it's a hard exam. The nurse checks her temp. She's febrile. Okay, that might explain some things, but her heart rate is 155, more than you would expect for her age and that temp. You give her some ibuprofen for the fever and the pain, and plan to come back to re-examine her. 30 minutes later, her heart rate is 142. She seems a little more at ease, but she's not interacting very well, and she's still holding her head that way, tilted just slightly to the left, but her chin down. You get her father to help hold her so that you can get a good exam. He holds her in his lap, so they're both facing you, and Dad has one arm over both of her arms and one that's cradling her forehead and holding her back into his chest. You examine her left neck, and it's very tender. You do some gentle tilting of her head back and to get her chin to come up, and she screams in pain. Now is the time, of course, to look in the throat now that her throat is open. So you take a quick look. Tonsils are a little red. There's some edema. The uvula is midline. Maybe there's some scant exudate. Her pain doesn't match her mildly abnormal throat exam. You summarize what you see to her father, and he does add that she has been refusing to eat today. Let's reframe. An ill-appearing child, albeit in this case mildly so. She has fever, she has throat symptoms, she has tenderness along the neck soft tissues with a throat exam that's not really consistent with those symptoms. Now, this could be a lot of things, of course, but a few clues will get us to what we need. Sylvia was quiet, and she said nothing the whole time you were there. Again, you are pretty impressive, but, we get the awe and admiration. But seriously, she just wouldn't interact with you, and she would not even look up at you. She wouldn't extend her neck. That's the biggest clue for me. It's almost the reverse Brudzinski sign. For meningitis, when you flex the neck and it causes pain, that's meningismus. But here, Sylvia doesn't want to extend her neck. This is typical of a retropharyngeal abscess. I'll explain. In meningismus, when you flex the neck, the meninges they're stretched, it hurts. Straightforward. We like that. With a retropharyngeal abscess, you are annoying the area that's infected. Do you remember way back in anatomy when you dissected the cervical prevertebral space, right? I know it's a long time ago, but recall that as an adult, the prevertebral fascia looks like a series of phyllo dough stacked one on top of each other, very fine layers. There's not much to see there. In children, it's a bit more interesting. In children less than 8 and typically around 4 and younger, there's a well-developed lymph node chain that runs along the prevertebral space in the cervical spine, like little raisins or chopped figs in the phyllo dough layers. They are there to surveil the cervical spine, to keep the deep tissues clear of microbes, since young children have so many upper respiratory tract infections. Over time, they are not needed and they eventually devolute. In children, though, that vertebrocervical chain usually can clear the random transient bacteria. They may drain the local infection. They neutralize it. They do their job. But sometimes, and I said sometimes, they've been here silent all these years and now infected. The reason it hurts to extend the neck is that you're extending all the phyllo layers and the figs and the fascia and the nodes, and it hurts. Flexion hurts in meningismus. Extension hurts in retropharyngeal abscess. What to do now? She needs an IV, she needs fluids, she needs antibiotics, and truthfully, a CT. The CT is important to confirm the diagnosis, but also to plan for conservative versus surgical management. In general, many of these abscesses that are under 3 centimeters in diameter can be treated with IV antibiotics as an inpatient, and we're just following them for clinical improvement. Well-formed abscesses greater than 3 centimeters in diameter, they're often drained surgically. Regardless, we need to admit them for the IV version of amoxicillin or ampicillin sulbactam. It's usually 50 mg per kg per dose every 6 hours, or clindamycin, 15 mg per kg per dose, about every 8 hours or so. And of course, ongoing hydration and airway monitoring. George is a 5-year-old boy who got sent home from kindergarten because of headache and neck pain. The parents think he's fine and then there isn't much going on. They just want a note for the school to send him back tomorrow. His father has an important business trip to go to, and his mother works and cares for George's younger twin sisters. The parents explain that he's had headache and neck pain from time to time. They've taken him to an optometrist. His vision is fine. They think he's having a hard time adjusting to having younger siblings. George just got some acetaminophen prior to his arrival. He's not very enthused to be here, and he humors you when you ask him questions, but just barely. His vital signs are all normal, and he says he feels okay. So, there's not much to work with here, and you're ready to discharge him when you notice that just something doesn't seem right to you. Mom and Dad seem okay, even if they're downplaying George's symptoms. The recent stress at home can definitely explain some regressive behaviors or maybe even some attention seeking. This just seems different. George is almost sullen. He holds his head down and just slightly to the side. When you point this out to Mom and Dad, you don't get too much of an explanation. There's no trauma, there's no real neglect here. You examine George again, and he really doesn't have full range of motion, or at least full spontaneous range of motion. He seems to have a weaker shoulder shrug on the left. And when you place your hand on his face and have him resist you and rotate to the left, he's weaker there than going to the right. What cranial nerve is that one? The accessory cranial nerve 11. It can get irritated and even show a partial palsy when there's a tumor that's growing in the posterior fossa. Farfar et al. In 2014 warned that persistent torticollis can be an early warning sign of accessory nerve dysfunction and a posterior fossa mass. In their study, 22% of children with posterior fossa tumors initially presented with torticollis. Now, this isn't the same as acute torticollis that comes and goes and you're finished with it. This is torticollis that's just persistent over weeks in someone who's not a neonate. In fact, the average time from onset to diagnosis in these children is almost 10 weeks. It's sad in one way, but it's a little reassuring to us in another because we have time. George is going to need an MRI based on the chronicity of symptoms in the abnormal neuroexam. In a perfect world, he would get it now. Now, we can risk his course if we don't connect with the parents and let them know what you're thinking. You don't want to be aggressively telling them that the sky is falling. They're going to see a well-appearing child and your credibility is going to be gone. So you don't want to be so reassuring or relaxed about it that they won't follow up either. A frank discussion about what needs to be done when and what the acceptable timeline is and what you can offer is a good starting point. Acknowledging that we don't know yet is important. If the pediatrician is accessible and they feel comfortable arranging this with him or her, that is just fine. I would still write a nice little note or make a phone call. Doing an MRI on a 5-year-old usually means some type of sedation. If that means admission to make it happen, so be it. The trick here is listening to that little voice that says, just doesn't add up, and making people happy is nice, but getting them what they need is where it's at. All right. Marco, Sylvia, and George presented in weird ways. I'll give you that. Let's talk about the good old musculoskeletal spasm and strain, how that presents, and what to do about it. After a very minor trauma or inflammation from a viral illness or really anything that irritates the sternocleidomastoid and trapezius muscles, they can cause a spasm, cramp, torticollis. We talked about rotatory subluxation and how that can present. Really getting a good history and physical is key to that cause. The good old muscular spasm of sternocleidomastoid is easy. Consider the pinch test. Let's call it the Torticollis tickle. When you see a cute little kid and you pinch his little cheek or you tickle his neck, he moves to that side to shield you from more tickly pinchies. Same thing when it comes to muscular strain. The side that is spasmed is usually protected by the ear. So let's say the right sternocleidomastoid is spasmed. It will pull the ear into it, and the chin may even point slightly to the opposite shoulder. Are you seeing it? Pinchy neck, ear shield. In these children, the affected sternocleidomastoid muscle is tender, and if you can get in there, it'll feel tight. When you examine the throat, the lymph nodes, they're all normal, reassuring. NSAIDs work really well in these cases. You can even give them a dose in the ED, let them settle and re-examine, and often they have a remarkable improvement on their exam. Cases like this will often resolve in about a week. Sometimes babies have minor birth trauma causing a hematoma under the sternocleidomastoid muscle, and that causes a little subsequent fibrosis. And this will be congenital torticollis, right, or a stiff wry neck in the neonate. Now, you're probably not necessarily going to make that diagnosis in the ED, but people come to us for all kinds of things. So think about all of the other congenital, infectious, traumatic etiologies, but just know that this is a congenital thing as well, and that well-appearing child needs follow-up and physical therapy. Let's go over a few miscellaneous causes of torticollis in a biz-buzz manner, rapid fire. Maybe the teenager you're seeing right now likes cocaine or any other drug that causes dopamine 2 receptor antagonism. Maybe he has no substance use issue, but he's agitated and you have to give him some haloperidol to restrain him chemically. He develops a dystonic reaction. His dystonia just happens to show up like torticollis. You give Benadryl, diphenhydramine, IM or IV, and that usually does the trick. Okay, same teenager is back after vaping cannabis. He has a coughing spell and now neck pain, and he's holding his head to the right. It's obvious, right? By the way, I love my teenagers, but real is real. Anyway, with more prompting, maybe his chest is a little sore too. Chest x-ray shows pneumomediastinum, another potential presentation associated with neck pain and torticollis. A 6-month-old is brought in by mother for vomiting and holding her neck in what she calls a weird way. The child is usually fed 6 ounces of formula before she's put down to sleep. She has reflux and arching of her back and neck that usually resolves soon after, called Sandifer syndrome, arching the back, sometimes torticollis, strained neck muscles from gastroesophageal reflux. A 7-year-old is brought in for chronic neck pain, chronic back pain, and now he has a wry neck. He has torticollis. And already you're thinking, okay, I'm not sure what I'm going to contribute here in the emergency department, but this is a good example of exposing the area that we want to examine. So many times we just examine people over their clothing and we miss this. You examine his back in a gown and see that one of the scapula is higher than the other. If you could go back in time and ask him when he was an embryo how he felt about the interruption of the descent of his right scapula during his development, he might tell you all about it. The scapula runs so high for him, it never descended, that an abnormal ossification occurs between the scapula and the cervical spine. It fixes the scapula to where it is, high riding. This is called the omovertebral bone. Omo, O-M-O, meaning shoulder, and vertebral, bone, right? So omovertebral bone. It's also called Sprengel's deformity. It's the most common congenital abnormality of the shoulder, and it can present as, you guessed it, torticollis. Usually this is conservative management, and surgery is reserved for major limitations in function. Now, the list goes on with potential infectious, oncologic, congenital, rheumatologic, and other causes of stiff neck and torticollis, even if they're not very common. But those other things like Guillain-Barré or osteomyelitis or myasthenia and all of those other things that we mentioned will present with something else to get you to the diagnosis. They're not going to present with just torticollis. So what we've talked about so far can present only as a stiff neck. Of course, a stiff neck can present in a constellation of other symptoms, and those other things are going to get you to where you need to be. One more thing to add to your pediatric emergency playbook is an atraumatic rotatory subluxation. Remember poor Marco with trisomy 21 and a minor fall? He had a predisposition to rotatory atlanto-axillary instability, subluxation with just minor trauma. So, same case, no fall, no predisposition. An atraumatic, spontaneous rotatory subluxation of the atlantoaxial joint. Healthy toddlers can get this after a benign upper respiratory tract infection. Basically, the inflammatory cascade with all of its interleukins and tumor necrosis factor and all the things that make your serum sizzle, they tenderize your ligaments and make them lax, if only transiently. We went from phyllo dough to meat tenderizer, but you can follow what I'm saying here, right? So let's say Johnny, he's 3, he has a URI about a week or two ago. He comes in after a nap with rotatory subluxation. It's also called Grisell's syndrome, G-R-I-S-E-L, Grisell syndrome. It's the same treatment, pain meds, soft collar, outpatient follow-up, if there are no concerning findings. With a good history and exam and preloaded with torticollis pearls, we're going to get there. X-rays can be used in older children, but they're not sensitive enough if you're looking for rotatory subluxation. Plus, getting a young child to keep his mouth open for an odontoid view is, well, good luck on that one. If you think there is a lateral neck mass or lymphadenitis causing neck pain or torticollis, then, of course, an ultrasound makes sense. But I'll tell you, if you're really looking at torticollis, it's either exam, treat, and reeval, or it's CT. In some cases, an MRI may be more helpful. Labs don't usually help unless you're trying to rule out other things. Maybe an LP if there's more neck stiffness than torticollis. Like anything we do, we think it through. Is it traumatic? Is it infectious? Is it oncologic? Is it rheumatologic, congenital, metabolic, or tox? Or just plain weird? If you can explain it comfortably, and there's a cute little torticollis tickle, the ear moves to the affected side, and the patient improves with your treatment, you're golden. Otherwise, it's worth a Google. Thank you for listening. Until next time, remember, you are the champion for the child in front of you. Take care.
Thank you for listening to The Playbook. We welcome your comments, questions, and feedback. Email Tim at coach@pemplaybook.org or drop by our website for show notes and more strategy at pemplaybook.org. See you there.